Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. They will be useful to fourth year students for exam going, for theory exam as well as oral exam, and they will be also helpful when they do internship and they start private practice. Today, in continuity with the previous lecture, how you collect CSF, that is lumbar puncture. So we'll be discussing on lumbar puncture. So lumbar means it is a lumbar spine. From lumbar spine region, when you collect the CSF by doing a puncture, we call that as a lumbar puncture. It can be done in two positions. One, lateral position. We call either right lateral or left lateral position. And second method is in a sitting posture. These are the two common things which are being done. We'll be going in detail. It is also called spinal tap. You can see here, this is done in a sitting posture. Here it is done in a supine posture, but it is lateral. So either it is right lateral or left lateral position. This is again sitting posture. So we'll be discussing under few headings: introduction, indications, contraindications, method, and then complications. So usually lumbar puncture is done between L2, L3 spine or L3, L4 or between L4, L5. It is a method of obtaining a CSF for examination, and this lumbar puncture can be done for obtaining a CSF for analysis. Also, lumbar puncture is done for investigative purpose, say in case of myelography, for diagnostic purpose, that is for CSF analysis, for therapeutic purpose. It is done in some of the condition where you inject some drug into subarachnoid space and while giving spinal anesthesia. We'll be going in little more detail as we come into indications. When lumbar puncture cannot be performed because of few contraindications, you can go for cisternal puncture, and that puncture is between C1 and C2 spine in cisterna. That portion is called cisterna. So hence it is called as a cisternal puncture. But this has to be done by an expert only, because if unexperienced person does that, he can create lot of complications. In children, it can be fontanelle puncture, that is puncture into the lateral part of the fontanelle, and it is very commonly done in a neonates. So these are the three common methods which are being utilized for obtaining CSF. So the most common method which is utilized is lumbar puncture between L2, L3 spine or L3, L4 spine. You can go for a ventricular tap, not very commonly being done, but while doing a ventricular tap, you will have to do a burr hole, and through a burr hole, you will have to introduce a needle into lateral ventricles and then obtain the CSF. Very, very rarely this is a method which is utilizing for obtaining a CSF for analysis or for what we call as investigations. Usually a second alternative method to the lumbar puncture which is being utilized in children is fontanelle tap, mainly the lateral fontanelles. And then the third method which is being commonly utilized is puncturing the cerebromedullary cisterna, and that is done when lumbar puncture is contraindicated. So these are the four methods of which the ventricular puncture is very, very rarely done. Now while doing a puncture, it can be done in a sitting posture or supine posture. It can be done under a radiological guidance or on an ultrasound guidance. Cisternal puncture or cervical puncture or ventricular puncture. These are some of the puncture which are not commonly being done. And in neonates, you can go for a lumbar puncture or you can go for fontanelle punctures. These are the different methods which are commonly being utilized. Lumbar puncture or spinal tap is carried out by inserting a needle into the lumbar subarachnoid space to obtain a CSF, and then CSF is sent for analysis. So it is a simple procedure where the sample of CSF is obtained for analysis. This test is utilized in many conditions. We'll be going through in indications. There is a music band. This is also called spinal tap, but this is not the spinal tap. When you puncture in a lumbar spine between L3 and L4 or between L4 and L5, that is lumbar puncture. This is cisternal puncture, where you puncture the cisterna magna, or we call cerebellomedullary cisterna. That is cisternal puncture. It should be done only in an expert. And when you do a fontanelle puncture, that is mainly in the lateral side of the fontanelle, that is called fontanelle puncture, commonly done in infants and in newborns. Lumbar puncture, cisternal puncture, fontanelle puncture. These are the three common sites where it is being done, and of that the most common, unless contraindicated, always lumbar puncture is the first choice. It is also called spinal tap. Now indication can be for diagnostic purpose like myelography, quick and state test. Also you can utilize the same word for diagnosis, only the little twisting of the things is being done. So investigation is indirectly a diagnosis of a disease only, but separate word is being utilized, that is for CSF analysis. And third word, which is very commonly being used, is for therapeutic purpose, where you perform ventriculoperitoneal shunt, ventriculoatrial shunt in case of raised intracranial pressure or in a case of hydrocephalus, etc. Or if any person who has developed intracranial pressure with herniation, these will be the procedure which will be for therapeutic purpose. In some of the malignancy, you can inject the drug, that is chemotherapy, can be given through puncture. In case of pyogenic meningitis and tubercular meningitis, you can inject anti-tubercular drug, or even steroid is being injected in person with tubercular meningitis. You can utilize immunoglobulins, IgG, in case of tetanus, and particularly in a person with a chronic debilitating pain because of metastasis. Analgesic can be injected by doing lumbar puncture. So in case of a non-communicating hydrocephalus, normal pressure hydrocephalus, and intracranial pressure with herniation, it is absolutely one of the major indications for therapeutic purpose in these conditions. And while giving spinal anesthesia, again this is a mode of giving spinal anesthesia. So primary indication for emergency spinal tap is for CNS infection. And second indication for an emergency spinal puncture is in spontaneous subarachnoid hemorrhage. This too becomes topmost on the list. And when you want to measure the CSF pressure, one of the easiest method is by doing a lumbar puncture and measuring the opening pressure of CSF if you want to rule out raised intracranial pressure. Also, it is done to inject the dye or air in subarachnoid space to prepare to take an X-ray of brain and spinal cord. Particularly, there is one procedure which is called as pneumoventriculography. This is done to identify the size of ventricles in case of hydrocephalus, and also to inject the medication or anesthetic drugs directly into the subarachnoid space. We have mentioned few of those. And to remove the CSF to relieve the pressure in case of intracranial pressure elevation, also in a case of herniation. This will be one of the procedure which can be done to remove the CSF. But in person with a herniation, usually lumbar puncture should not be done because it will give rise to coning. So in that particular person, ventricular puncture will be preferred to remove the CSF. So for investigative purpose, or we call diagnostic purpose, ideally the word should be both are almost synonymous. Suspected case of meningitis, particularly bacterial, viral, tubercular or fungal. If you are suspecting a meningitis, person has come to you with a high grade fever, headache, vomiting, convulsions, and there are meningeal signs in the form of neck rigidity, Brudzinski and Kernig sign. You must send CSF for analysis. Second most common indication is in a case of subarachnoid hemorrhage or intracranial hemorrhage. In that particular, you want to find out the presence of RBC in CSF. You will be asking for CSF analysis. Any person who gets a sudden severe headache and you are suspecting secondary etiology in the form of meningitis or subarachnoid hemorrhage or intracranial hemorrhage, CSF analysis is absolutely must. Other way is any person who has got an altered level of consciousness or sudden coma and you are suspecting infection or vascular etiology. Again, it is same. First two common indications. If any person who comes to you with seizures and you are suspecting secondary etiology, suspected secondary etiology, or it is symptomatic, or we call seizure with local signs or focal signs, you must look for CSF analysis. And in a person whom you are suspecting raised intracranial pressure, for measurement of intracranial pressure by manometry, that is another important indication. If you are suspecting any intracranial pathology on a clinical ground, fever with meningeal signs, suspected secondary metastasis or primary malignancy, in case of leukemia, very occasionally you come across the case of Guillain-Barré or multiple sclerosis, we call demyelinating disease. In that case also you can go for CSF analysis and specific test can be done in suspected CNS infection like syphilis, abscess or encephalitis, rare viral encephalitis. Again, CSF analysis can be asked for. So you can use the word investigation or diagnostic purpose. And we have already mentioned that it is very useful in CNS infection, subarachnoid hemorrhage, normal pressure hydrocephalus to find out and confirm the diagnosis of normal pressure hydrocephalus, or in short we call it as NPH. It is also important in case of a demyelinating or inflammatory CNS disorders like multiple sclerosis, Guillain-Barré or paraneoplastic syndromes. And we have also mentioned that to inject a drug like anesthetic drugs in case of spinal anesthesia, as well as anesthetic drugs are also utilized for giving relief of pain and also for chemotherapy, and while you are doing a procedure like myelography. And also it will be one of the method by which you can give a relief in a person with idiopathic intracranial hypertension. In that condition also, it will be for therapeutic purpose by removing a certain quantity of CSF. So in general, infections, inflammatory, oncology, metabolic, spontaneous subarachnoid hemorrhage, in all these conditions for CSF analysis. As far as therapeutic purpose is concerned, analgesic, anesthesia, antibiotics, and we call anti-neoplastic, or we call chemotherapy. So these are some of the things, and also for diagnostic purpose by injecting a contrast media and do what we call as myelography. That is the most common way of doing investigations. CSF analysis is very useful. It is highly sensitive and highly specific for diagnosis of bacterial, tubercular and fungal meningitis. Also, it is highly sensitive and moderately sensitive in viral meningitis, subarachnoid hemorrhage, syphilis or abscess. Low sensitivity but high specificity in meningeal malignancy, and moderate sensitivity and moderate specificity in intracranial hemorrhage, viral encephalitis and subdural hematoma. This will be few conditions which we will have to keep it in mind and go for lumbar puncture and CSF analysis. Myelography is you inject a dye in a subdural space in a suspected patient of spinal cord disorders. Also, you can do a burr hole and inject a dye in a ventricular space of cerebral hemisphere and do ventriculography. If you inject a dye and air, it is called pneumoventriculography, and you can put a probe with a sensor for intracranial pressure monitoring. We call ventricular pressure monitoring, or you can put into a parenchyma. It is called parenchymal intracranial pressure monitoring, or you can put in an extradural space and you can do extradural pressure monitoring. So it will be indirect measurement of intracranial pressure by doing a lumbar puncture, and you can go for even quicken state test. We'll be showing you as we go further. So indirect measurement of intracranial pressure by lumbar puncture, and that is by using a manometry, and you can utilize that. And direct cranial measurement is done by ventricular, parenchymal or extradural. So that will be direct, and indirect is by lumbar puncture. Therapeutic purpose we already mentioned. It will be very useful in idiopathic intracranial hypertension. You remove certain quantity of CSF and reduce the intracranial pressure. Intrathecal drugs, like in a tubercular meningitis, you can inject injectable tubercular drug or steroid you can use in tubercular meningitis to prevent fibrosis and hydrocephalus. Antibiotic you can inject in case of bacterial meningitis. You can use immunoglobulins G, IgG in tetanus. You can use immunoglobulins and steroids in case of GBS. And anti-cancer drugs, or we call chemotherapy, in case of leukemia and gliomas. And you can go for VA shunt, VP shunt to reduce the intracranial pressure in a person with raised intracranial pressure, herniation, and also in case of hydrocephalus. And you can also do decompression. and you can utilize analgesics in person with terminal pain, or we call pain because of secondary metastasis or malignancy, anesthesia, antibiotic and neoplastic drugs. These are common therapeutic indications. Spinal anesthesia, which can be epidural, subdural. Mainly it is utilized while doing a surgery on lower limb or abdomen, or nowadays it is also done by giving spinal anesthesia at the level of thoracic spine, and also this is being utilized by injecting the anesthetic drugs to relieve the pain for intractable pain, particularly in terminal stage of malignancy and spinal metastasis. So this will be one of the therapeutic purpose, that is for pain relief in intractable pain because of terminal stage of malignancy or even in case of secondary metastasis. Lumbar puncture or thoracic paravertebral blocks, very commonly done in a post-operative analgesia, particularly for thoracic surgery, breast surgery, cholecystectomy, ureteric surgery, hemorrhoids, appendicectomy, video-assisted thoracoscopy surgery, breast, etc. Also for fractured ribs, then to control hyperhidrosis, liver capsule pain after blunt trauma, acute post-herpetic neuralgia, etc. You can utilize paravertebral blocks, thoracic or paravertebral blocks, thoracic or lumbar paravertebral blocks. Indication for CT prior to lumbar puncture, particularly in older individual, immunocompromised host, person who is known to have a CNS damage, person with seizures, abnormal level of consciousness or altered level of consciousness, focal findings, focal neurological deficit, and person who has got papilledema and there is clinical evidence of elevated intracranial pressure. Now, most important part is in which condition lumbar puncture should not be done. Absolute contraindication is any person who has got a raised intracranial pressure clinically in the form of severe headache, vomiting, projectile vomiting, blurred vision, and he has got bilateral papilledema. And he has got a focal localizing sign, which are more in favor of herniation signs. Second contraindication is any person who has got bleeding disorders, which can be genetic like hemophilia, or he is on oral anticoagulants or injectable anticoagulants, and his INR is above 1.5. If over the lumbar spine region, if the person has got severe skin infection, or person in whom you are giving a thoracic procedure and person has developed an empyema, in that case also lumbar puncture should not be done. Or if he is sensitive to local analgesics, particularly say like xylocaine, then also, because if you cannot give a xylocaine, lumbar puncture will be very difficult to perform. And if any person who has got raised intracranial pressure with suspected herniation and there is a lateralizing sign, we already mentioned that, and acute spinal cord injury, particularly if the person has got cervical spine injury or lumbosacral spine injury, or if a person who has got a SOL with raised intracranial pressure where the intracranial pressure may not be so much elevated, but this will precipitate herniation or we call coning. So that should be kept in mind. Relative contraindication, mild raised intracranial pressure, where lumbar puncture can be done after lowering our intracranial pressure by either mannitol or by using glycerol or by using hypertonic saline, etc. Also, you have to be very cautious if a person is non-cooperative, if person is having seizures, if person is having involuntary movement, if person is having severe spinal deformity like scoliosis, kyphosis, gibbus, or ankylosing spondylitis, etc. And if any person who is suspected to have prolapsed intervertebral disc or fracture spine, or he has undergone a recent spine surgery, it is very cautious. We should decide depending upon the patient to patient, and that we put into relative contraindication. And in those groups, you will go for cisternal puncture, and that should be done by an expert. So, contraindication in any person who has got a raised intracranial pressure with brain tumor, cerebral hemorrhage, abscess, epidural or subdural hematomas, etc. Or if there is a clinical suspicion of uncal herniation, or there is a therapeutic use for lumbar puncture to reduce intracranial pressure. So in those conditions, you will have to decide whether lumbar puncture can be done or not. And in the person in whom you want to do a lumbar puncture, who has got raised intracranial pressure, you must perform CT scan in a person above the age of 65 who has got a reduced or altered level of consciousness. Recently, along with raised intracranial pressure, person has got seizures, focal neurological signs, and on ophthalmoscopy, you got papilledema. You should be very cautious before doing a lumbar puncture. We already mentioned bleeding diastasis, skin infections, abnormal respiratory pattern which suggest a herniation signs. If person has got hypertension with bradycardia and altered level of consciousness, means person is developing Cushing triad, severe deformities, spinal cord trauma, etc. We have already mentioned majority of those. If even INR is more than 1.5, or person has got already well established bleeding disorders and platelet count less than 50,000, infection at the puncture sites, person is having obstructive or non-communicating hydrocephalus, SOL, raised intracranial pressure with papilledema, these are all contraindications. Now we are going through the method. In methods, I am first mentioning the heading and then I will show you some slides. Obtain the informed consent, meaning you have to explain the person what you are going to do, for what purpose you are doing, what will be the benefit person will get to the person and the relative, and obtain the consent of patient and relative. And if patient is unconscious, then relatives. Gather all the material what is required for lumbar puncture. Injection atropine has to be given to prevent vasovagal shock. Proper position. Then locally you will have to give local anesthesia, insert the needle with sterile technique and measure the opening pressure and collect the CSF for analysis. Now we'll be going through one by one. So before the procedure, proper position is very important. We'll have to identify where you want to do a lumbar puncture. Mark the site. You open the tray. Prepare and drape. Means you take all antiseptic precaution. Do proper skin sterilization. Drape. Then give cutaneous anesthesia. Or you can use a deep anesthesia. Then you can perform the lumbar puncture. Attach to the manometer and obtain the opening pressure. Now after obtaining opening pressure, now collect the CSF, withdraw the needle and close the lumbar puncture site by a proper technique. So this will be the entire procedures. So now we are starting with first. You have to explain the reason for doing a lumbar puncture. You have to explain the potential complications. And after informing all those things, you will get signature or written consent. Ask the history of allergy to local anesthetics before giving a local anesthesia. So inform and explain and then get a consent. After getting consent, position of the patient is very, very important. Person should be close to the edge of the bed as possible in one lateral position. Most common position which is being utilized is left lateral position. Pillow under the head and between the legs. Head is flexed and leg is curled up so that almost we call knee chest position. Ask the patient to bulge out the lumbar sacral spine and carefully now open the lumbar puncture kit and put the cleaning solution in a reservoir. So this will be the kit which will be available. Everything is available in this, right from cleaning till collecting tubes, etc. So it will be containing spinal needle, 3-way stopcock, manometer, 4 specimen tubes, local anesthesia, drap, betadine solution. Everything is there in this tray. So all these materials are there: 4 test tubes, manometer tubes, syringe, needle, all this, 3-way valve, all those are available. Draping material, local anesthesia, everything is available. Then proper position, ideally it should be done in an operation theater only. So proper position is absolutely must. And after giving a proper position, it is called lying down position. Mainly it is always left lateral position. Commonest is left lateral position. Unless a person is left-handed, then he can go for a right lateral position. By and large, it is commonly this position. Or you can perform in a sitting posture. So position is absolutely necessary. This is the position which is being given, and you will select the site by using the highest point of iliac crest, which corresponds to L4 L5 spine or L3 L4 interspace, depending upon the patient whom you are selecting. By and large, it will correspond to L3 L4 intervertebral space. And in sitting posture, you can utilize L3 L4 spine or L4 L5 spine space. So knee has to be drawn up to chest, so we call knee chest position. So that is a must. And after giving that proper position, this will be supine position, or we call right lateral or left lateral position. This is what we call is a right lateral position, and here this is left lateral position. This is left lateral position. So depending upon the person convenience who is doing a lumbar puncture. So imaginary line at the highest point of iliac crest will correspond to L3 L4 spine space, and that is the best space you can go for. It is also called a two-fear lines, highest point of iliac crest. In some, it may be L4 L5 spine. So you can select one space above L4 spine. It will be between L3 and L4, and below it will be L4 L5 spine. So level of the iliac crest almost corresponds to L4 spinous process. So either you can go for L4 L5 spine space or L3 L4. Cleaning with alcohol, betadine, sterile gloves, draping, all those antiseptic precautions should be taken. After getting all those things properly, now local anesthesia has to be given. So you go the local anesthesia where you want to do a puncture, and after giving a local anesthesia, wait for a while. You get the needle, we call spinal needle or lumbar puncture needle. There are two types of needle available. One is called traumatic needle and second is called standard needle, which is available with stellate. Most commonly this is being utilized. This is another needle to prevent certain drawbacks of this standard needle, like traumatic injury. So there are different types and different size are available, 26, 25 gauze which are available, different types of needles which are available. After puncturing the skin, will be going through ligamentum flavum. This will be ligamentum flavum. Sorry, first skin, subcutaneous fat, then supraspinous ligament, interspinous ligament, and then ligamentum flavum. Sorry, I should not have said directly you enter there. So first you puncture the skin, fat, tissue, then supraspinous ligament, this will be interspinous ligament, and then this will be ligamentum flavum. And once you puncture the ligamentum flavum, you will touch a membrane which we call as dura mater, and you are in an epidural space. As soon as you just give a little force, you will get a give way and you will enter into a subarachnoid space. And once you enter into the subarachnoid space, now you will have to withdraw the stylet. So gradually you introduce in that particular space and enter into subarachnoid space. This is, you are introducing a needle. Now once you enter there, now you are withdrawing a stylet. As soon as you withdraw the stylet, you will see that the drop of CSF has come, means you are in the space. Now you will have to connect that to a manometer. You will find a difficulty in person with obesity, scoliosis, arthritis, particularly ankylosing spondylitis, non-cooperative person, anxious person, and if you get a severe deformities, etc. You will get a failed attempt, and then you can utilize in this particular group of people ultrasound guided or CT guided. Best is ultrasound guided. That is very easy. You can do a lumbar puncture using an ultrasound. So that will guide your needle where you want to enter. And once you enter into the subarachnoid space and you obtain a CSF, now you will have to connect to a manometer. This is, you are connected to a manometer by attaching the three-way valve, and this will give you opening pressure. So how much is the elevation of intracranial pressure? Indirectly it will give you indirectly measurement of intracranial pressure. So you will be using three-way. This will be a three-way valve and you are attaching to the manometer, and this will be the way you will be attaching, and you can see here it will give you a reading. CSF will rise in this tube and it will give you a reading, and that will be in millimeter of water. Roughly in any person it is between 90 to 180 millimeter of water. So after measuring that CSF you can collect in a test tube also after doing that manometry. So it will give you an idea regarding the opening pressure. Opening pressure in an adult can be right from 90 to 180. It will be very, very low in a person with an intracranial hypotension, or if there is a dry tap, you will not be able to measure the blood pressure. So opening pressure gives you a good idea regarding the person is having a raised intracranial pressure or normal pressure or low pressure. That idea can be easily obtained by measuring a opening pressure. At this particular stage, you can also go for what is called quick and state test. This can be asked as a short note or can be asked in your oral also. So jugular compression maneuver is also called as quick and state maneuver, where while measuring a pressure, what we call as opening pressure, now in that same position, you compress the jugular vein in the neck, and that will increase the CSF pressure, which will be recorded by increase in the level of CSF in a manometer. Decreased pressure at the lumbar puncture, lumbar sternal lumbar puncture indicates the blockage of spinal central canal. So if you have done a lumbar puncture and you are compressing the jugular vein and there is no elevation of pressure, that indicates there is a blockage. If there is a slight elevation, partial blockage, no change, complete blockage. And there is a good change on compression and comes back to normal on relieving the compression. It is normal space. There is no blockage in spinal canal. So this is how you compress either internal jugular vein or you can compress even an abdomen. But best is compression of the jugular vein and look at the rise in a CSF level in a manometer. That is quick and state test. So we already introduced that. So it is a measurement of CSF pressure in a normal. After doing a lumbar puncture, we call opening pressure. After compression of jugular vein, one jugular vein, both jugular vein, and observe the response during compression and after release. Method is after doing a lumbar puncture, connect the lumbar puncture needle to a manometer and then see the record after doing a puncture, that is opening pressure, after compressing one jugular vein, compressing both jugular vein, releasing the pressure and see the changes in measurements. Interpretation in normal, there will be smooth rise and equal smooth fall in a normal person. When you block the or when you obstruct jugular vein, if there is an obstruction in the jugular vein or superior vena cava, initially pressure will be very high, compression will not change any difference while compression or releasing internal jugular. If partial compression of spinal cord is there, then there will be slight elevation and very slight fall. And in complete compression, there will be no change on or after compression of both internal jugular vein. This is the importance of quick and state test. So after finishing that, you can collect that CSF in a test tube. Usually you collect the CSF in a 4 test tubes, one for chemistry and immunology, we call chemistry, one for microbiology and one for cell count, that is for differential count and cell count, and for microbiology, that is for detecting bacteria, virus, etc. Whenever you are collecting a CSF in a test tube, you can look at the physical appearance, that is color, clarity, turbidity, etc. can be easily seen at that stage only. So after CSF collection, you are collecting in a 4 test tubes, one for culture and sensitivity, that is gram stain, culture and sensitivity, one for glucose and protein, that is we call chemistry, one for cell count and differential count, and one for special studies. And after that particular, you also check for closing pressure with manometer. You reinsert the stellate and remove the needle with one smooth motion, clean the back and cover the puncture sites, or we call seal the puncture sites, so that there is no CSF leak. Now there is one word which we commonly should look for is traumatic tap. So suppose the first sample of CSF what you are draining, if it is red in color, look at the second sample and third sample. If all the three are equal color, equally red color, it will be in favor of intracranial hemorrhage. And usually in those all the 3 test tubes there will be no clot and you will see xanthochromia and you will be able to detect hemosiderin or hematoidin crystal in CSF. While in a traumatic tap, the first will be reddish in color, the third bottle will be absolutely clear, and second bottle might show you a mixture of the two, means maybe light red in color. And usually traumatic tap will show you clots. Mainly in the first test tube will be clear. You will be able to see a clots. There will be no xanthochromia and supernatant will be absolutely clear. This will be the way you try to differentiate traumatic tap from intracranial hemorrhage. Because if it is a traumatic tap, the interpretation will change grossly. You will not be able to identify whether there is an intracranial hemorrhage or not. Means you will not be able to differentiate subarachnoid hemorrhage, intracranial hemorrhage from a normal person. It will give you a false reading. So smoothly reinsert the stylet and smoothly remove the entire needle, and then this is removal of the needle. Apply the pressure and then seal off, tincture benzoin seal, and then you can put a tape, bending tape, so that you prevent CSF leak. Now you will do a recording. You will label the tubes. You will give your clinical appearance, that is physical appearance, record the immediate results, opening pressures, whether it is clear, turbid, what color it is, what was the pressure, etc. should be recorded. And then by and large always give a head low position for minimum 1 to 2 hours. And particularly in case of a raised intracranial pressure, after reducing the pressure by IV mannitol, then only you should perform a lumbar puncture. And person is given head low position for a longer period. And while removing the CSF, you will have to remove as much less quantity as possible to prevent coning. This is a precaution you should take. In a person in whom you get a dry tap, ask the anesthetist or a neurologist to perform the lumbar puncture. Or you can go for a ultrasound guided lumbar puncture. And very rarely you require CT guided or fluoroscopy guided lumbar puncture. Ultrasound guided gives a good. Cisterna magna tap should be done only by a neurologist. We already mentioned all these things. So you can perform in sitting posture, radiologically guided, and only experts should perform cisternal puncture or cervical tap. And fontanelle puncture in infants can be done easily. So fontanelle puncture is usually done in a person where lumbar puncture is contraindicated, and also cisternal puncture is done only if the lumbar puncture is contraindicated. I've already shown you this slide before. The commonest complication is headache, which will be almost in 10 to 25% of the people, and which will be because of low pressure headache. And person might have a small leak which will give rise to low pressure, and that will give rise to chronic headache. You might have a bleeding at the local site. You might introduce an infection from outside if antiseptic precaution is not taken properly. Local bleeding is very commonly because of traumatic tap, and which can lead to epidural hematoma. If you have not ruled out raised intracranial pressure and you have performed a lumbar puncture, you can induce brain herniation, and person can develop cardiorespiratory arrest, we call as a coning and cardiorespiratory arrest. Sometimes the person can develop subarachnoid epidermal cyst. These are some of the common complications which you can come across. So headache is most common. Very rarely you can develop apnea, chronic back pain because of traumatic lumbar puncture, disc herniation if the needle you have punctured the disc, bleeding and CSF leak, infection, hematomas, epidermal cyst, Transient ocular muscle palsy can happen. You can create a trauma if the needle is not pushed properly. You can damage the spinal nerve roots, and very rare, but can happen if a person has got severe raised intracranial pressure and you perform a lumbar puncture, because it is absolute contraindication if the person has got herniation. Even if he has got an uncle herniation, lumbar puncture should be contraindicated. So brainstem herniation can occur. So headache, brain herniation, bleeding, infections, dry tap, hematomas, low pressure headache, spinal cord injury or nerve injury, CSF leak, etc. are the common complications. While giving a local anesthesia, you can have anaphylactic shock, vasovagal shock, local hematoma or bleeding, introduction of infection from outside, traumatic injury to spinal cord or to the spinal nerves, trauma to the ligaments, herniation, particularly coning, and person can even have a cardiorespiratory arrest, low pressure headache, particularly if the large quantity of CSF has been removed or person has got CSF leak, chronic backache, and if not performed properly, dry tap. These are all the common complications. This is a big list. Post lumbar puncture headache, backache, bloody tap, dry tap, infections, hemorrhage, damage to the nerves, dysesthesia, post-dural puncture, cerebral herniation, rare but can happen. So these are all the common complications. You can see here a jet of a blood because you have punctured one of the artery. So you can get cerebral or spinal herniation, cranial neuropathies, nerve root irritations, low back pain, stellate associated problems, infections, bleeding, post-dural puncture headache because of chronic spinal leak, dry tap. So always keep it in mind. Dry tap can be because of improper position of the lumbar puncture needle, or lumbar puncture needle has been blocked by blood clots or by tissue, and in that case you reintroduce the stellate and see that you obtain a CSF, and if it is not obtained even after reintroduction of stellate, means your position of the needle is not proper. So re-perform at other sites. In case of a myelography, contrast media can also produce complications like seizures, allergic reactions, etc. Apart from complication of lumbar puncture. This is showing you a epidermal cyst, very rare complication due to use of a stellate. Very odd complications. So almost I've covered up majority of things related to lumbar puncture, how you do it, what you collect, what you can do, how you measure the opening pressure, how you do the quick and state test, etc. Quick and state test can be asked as short note, and indications, contraindications, you should be aware of it before doing a lumbar puncture. So I end my lecture here. If you feel this lecture is helpful to you, please don't forget to press button like, give your suggestions so that I can improve and I can give a better performance. So I thank you again for taking out time. I know that your time is valuable and I appreciate you have spent some of the time with me. And if you feel that this is helpful to you, you can also share with your friends. See you in next lecture.